Thank you all for coming. I'm really excited to see everybody here to learn about basic science. It's not a sitcom, if you misread the title, so sorry for that. I still remember back to high school, actually, my physics teacher told me that people who understand things too well can explain it. And I think it was an admission from him, and also made me think about it. It's very true, right? If you think about those people out there who just get it, right? A lot of times it's just like, why doesn't it make sense to you? So I'm here to tell you this didn't make sense to me at first. So hopefully, like my journey through really understanding the IL-17 pathway will help us hopefully, get this message across a little better. This presentation is sponsored by UCB, but it's a non-CME presentation. But I'm really excited to be able to talk to you about the science of psoriasis and how we understand it right now. So of course we know that psoriasis is a skin disease that has a lot of comorbidities and other associated immune-mediated issues with it. So we know that psoriasis in the skin is very common, but there's a high preponderance of joint disease as well, along with higher incidences of other inflammatory diseases like inflammatory bowel disease. And there's many forms of psoriasis. We have, of course, the plaque psoriasis we're all familiar with, but also guttate, inverse, erythrodermic, pustular, palmoplanar. So a lot of different flavors and varieties, and people can have combinations of these. We've learned through the years that certain subtypes have a higher association with, for example, psoriasis in the joints, right? So psoriatic arthritis has a high connection with scalp psoriasis, for example. In terms of the pathophysiology of plaque psoriasis, I think it's important that we understand that this has really evolved through the years very much. And it was first thought that psoriasis was that prototypical Th1 disease quite some time ago. But our understanding really has evolved, I think, over the last 20 years or so to a very nuanced understanding of psoriasis. And when you think about where it all starts, we think about the activated T cell, the activated dendritic cells, and that leads to a whole host of downstream events that happen. And you can see here, and I actually don't have a pointer, so I'm not going to wave this around pretending, but this is a pretty busy slide. On the left side, you'll see a lot of mediators, and I want to follow this central pathway here through IL-23, the Th17 cell, and IL-17, because that really is where the money is in psoriasis these days. And I think what's really important to think about also, it's not just a one-way direction that psoriasis forms. We know that clinically, people have these plaques, people express psoriasis over, we think, their whole lifetimes, generally speaking, right? It's a chronic disease. And because of this, you also have multiple mechanisms in place that really serve as a feedback loop. So when we think about the way
See if you can get the microphone closer because it's hard to hear.
Okay, sorry about that. So I'm going to be a little closer to the microphone. So when you think about the inflammatory cascade, there's not only the initiating events in psoriasis that happen with those T cells, the activated dendritic cells, there's also this feedback loop that really makes it a progressive and long-standing disease process that's really critical to our understanding of psoriasis and critical in the treatment of it also. We see here all the major players that we know about in terms of treatment, and we'll highlight them here. You see in the little box there, there's the phosphodiesterase starting from the left, but also TNF-alpha, IL-12/23, and IL-17A and F. And I think there's a lot of different ways we can look at this. Of course, our earliest mechanisms that we targeted in terms of biologics were TNF-alpha inhibitors. And back then, it really was thought to be the central pathway. But we know that TNF-alpha is also involved in a number of other things. And there's a couple of things that we really would rather not hit, right? Protection against infections. We're starting to see a little higher risk of non-melanoma skin cancers with certain TNF-alpha inhibitors. So there's reasons we want to have a more precise and targeted mechanism. And that's where the rest of the IL-23, Th17, IL-17 pathway. And I think one of the interesting things that has come out really is thinking about not just psoriasis as a Th17 disease, but rather as an IL-17 disease. And that's a nuance that's really been published in the literature over the last just few years. And I think it's important because it captures this feedback loop. One very interesting thing is that in psoriatic lesions in the skin, you actually don't have necessarily very, very high numbers of T cells. So it's not all this one-way direction. You're actually having a lot of epithelial sources of IL-17, such as neutrophils and mast cells, that seem to play a big role in really perpetuating the psoriasis. Actually, some of that work we showed recently in a mouse model of psoriasis where we abrogate neutrophils, we get rid of neutrophils, and you actually cannot mount much of a psoriatic lesion in that mouse. So there really does seem to be an interplay of multiple factors here where IL-17 is that proximal and really key regulator of psoriasis, even more so than perhaps the backwards Th17 pathway. Now, when we think about the conceptual approach to psoriasis, really we start all the way back in 50 years ago, 50 plus years ago. It really was thought to be keratinocyte mediated, right? It was all about the keratinocytes. And then work really started to focus on targeting actually lymphocytes in some ways, right? So some of the early work, Alice Gottlieb, Jim Kruger, they really showed that cyclosporin and certain other medications such as methotrexate help to treat psoriasis. Since then, though, our understanding really has evolved very much. So we had that Th1, Th2 paradigm for a while, but really it was in the early 2000s that we started learning about this Th17 pathway. And we started realizing that we kind of had it backwards, right? Because we know that IL-12 seems to be the central mediator in promoting the Th1 pathway. And it was originally thought that this was what started psoriasis, but that's actually not the case. The Th17 pathway was actually found by accident. And in a laboratory, they were actually trying to make these cells that expressed IL-17. And the only way they were able to do that was by blocking interferon gamma. And so they showed that by blocking Th1, they were actually able to generate an IL-17 response. And that really shows that the first step in the pathway is this whole Th17, IL-17 pathway. Everything else kind of just follows on from that. When we think about Th1 also, you think about that IL-12, there's actually been research in the last 5 years that shows that in an animal model of psoriasis, blocking IL-12 actually makes psoriasiform skin lesions worse. So that was really interesting when it came out, right? Because we think about the way that our medications have been really developed. We thought about the IL-12/23 pathway for a while. And initially it was thought that IL-12, that P40 IL-12, was that central role in psoriasis. And since then, it was actually understood that it was the other arm, the IL-23 arm, going to Th17, IL-17, that was more important in the long run. And so I think that was a really interesting shift in our understanding of psoriasis throughout the times. So in 2005, that Th17 lineage was really fully elucidated and described, and we saw that there was increased IL-17A positive cells in psoriatic skin. In 2009, we started hearing about different isoforms of IL-17, and that's really going to be the focus later on. I'll try to give you little kind of pearls about each one, but there's a whole family here of cytokines that are related. Our treatments really have evolved also with the landscape. So we have the TNF-alpha inhibitors, as we mentioned earlier, also the IL-12/23, and that's evolved nowadays to IL-17A, IL-23 inhibitors, IL-17 receptor inhibitor, as well as the phosphodiesterase inhibitor, of course not a biologic, but an oral medication. And really our approach and our goalposts for treating psoriasis have shifted, right? What's really amazing nowadays, if you think about it, is that the average, and I don't know, sorry, it keeps going forward by itself, so I'm gonna fight the PowerPoint a little bit. But our goalposts have changed, right? In the old days, actually at the very beginning, with our first TNF-alpha inhibitors, we were talking about mean PASI improvements. What were those mean PASI improvements? Around a PASI 70. So the average patient got to about 70% improved with the earliest TNF-alpha inhibitors. And then we started looking at these cutoff thresholds, PASI 75. And nowadays, we're really talking about PASI 90s and PASI 100s, where we get the majority of patients actually to PASI 100 improvement at whatever our goalpost is in time. So that can be as early as 4 months from starting treatment that we get the majority of patients to PASI 100. And that's really quite an impressive thing. If you think about the average biologics nowadays, we are actually getting people to 90 to 95% clearer on average with most of the medications that we have. So it's really very good for our patients. But the question is really, what are the trade-offs and what are some of the nuances and details? So we'll get into a closer look at each of the IL-17 cytokines. So this family of cytokines is linked to the pathogenesis of inflammatory disease. And so these were originally discovered in T cells, and IL-17A was actually the first one to be discovered. And they're now known to be secreted by all these other cells. So I mentioned earlier, the T cells actually may not be the most important item when we're thinking about what secretes IL-17 and what leads to this pathogenesis of psoriasis. There's a lot of other cell types in there. There's immune-like cells that have this feedback loop. The neutrophils seem to have a critical role in this feedback loop also in promoting the cytokine, I don't want to say cytokine storm, but certainly that increased inflammatory milieu in the skin. What we also know is there's certain immune-mediated inflammatory disorders outside of psoriasis that are involved with IL-17, so we'll cover some of those as well. And there's also some element of host defense against infection. When we think about the full picture of IL-17 family members, we actually have IL-17A, B, C, D, E, and F. Okay, so all of those have been elucidated now. They're all related cytokines, and they have different functions. So we kind of tend to think about IL-17A and F together. I'll get to why in a little bit. But this is really our central kind of two members of this family that have a role in inflammation and psoriasis and defense against mostly fungal infections. Joint inflammation perhaps in IL-17B, but we'll get into the details in a minute. So first, when we think about IL-17A, we know that IL-17A is markedly overexpressed in both psoriasis, but also other inflammatory-mediated immune disease such as hidradenitis suppurativa. And when you think about the synovial fluid, really IL-17A and F are markedly elevated in synovial fluid also. And what I think is an interesting subject also is that when you look at the basic science of looking at cell cultures and taking that in vitro work and linking it to clinical findings, it doesn't always compute necessarily very well. And what I mean by that is when you think about IL-17 by itself, it doesn't always have the highest efficacy in suppressing in an animal model necessarily keratinocyte overgrowth. But it's really when you combine it with TNF-alpha and other cytokines that are also in that milieu that you see the marked effects that we see in our patients with psoriasis. So it's not a simple one-way street. It's really this orchestra of various cytokines that play together to create the pathology that we see on the skin. When we think about the role in joint inflammation with IL-17B, there have been some studies looking at IL-17B and joint inflammation. I will note IL-17B and D have actually been shown to be decreased in psoriasis skin. So those two members of the family, they're also most homologous to each other. So IL-17B and D, we kind of think about sort of similarly. IL-17B, I don't know why it keeps advancing, sorry about that. But IL-17B does seem to be involved in joint inflammation in some way. So when they had an animal model of induced arthritis, it actually showed that there were higher levels of IL-17B. So that's an area where there might be some research eventually, but there's a lot of other areas where IL-17B is involved. It's such as the gut epithelium. So really the question here is the trade-off for blocking IL-17B going to be worth it in terms of that extra little benefit you may have in the joint inflammation? When I think about IL-17C, this is kind of like IL-17A and F mini in some ways. And what I mean by that is they seem to have overlapping roles. So when you look at IL-17C, it actually has similar roles in inflammation as IL-17A and F. One critical difference is that IL-17C is actually expressed by epithelial cells rather than by T cells. So one interesting thing about IL-17C is that you actually don't see it in the initiation phase of psoriasis, but you actually will see it participate in that chronic inflammatory loop. One of the really interesting things about this is that when you see that paradoxical TNF-alpha induced psoriasis, right? We've all seen that. It's actually fairly common that we'll see it. One of the earliest things that happens is that you have elevated levels of IL-17C. So it does, I think, have some role in participating in the inflammation that we see with psoriasis, but it seems to be probably to a lesser degree and only in that feedback loop as compared to IL-17A and F that we talked about earlier. The pathogenic role of IL-17D really isn't so clear. This is the newest member of the IL-17 family, and we're not really quite sure what it's involved in. We do know that levels of IL-17D are elevated in rheumatoid nodules, right? So there's some implication that maybe it's involved in this joint disease. And it does also affect some of the similar cytokines. IL-8, we think about that neutrophil chemoattractant. It does seem to have a positive effect on that, just like the other IL-17 members. One of the issues, though, for IL-17D is that it also has some role in cancer and as well viral immunity. So blocking it might be deleterious to some of those other arms where it has more of a regulatory role. So IL-17D is there. IL-17E I think about as kind of the more mysterious member of this family. So IL-17E is also known as IL-25. That's actually how it's more commonly known, I think. But it's interesting in that it's unique, that it seems to be more of a Th2 cytokine in a lot of ways. IL-17E is actually overexpressed in atopic dermatitis. You see that also with IL-17F and IL-17C to a degree, but this is more so. So it's involved in other things that you would think about that type 2 response, right? Asthma here, but also in skin inflammation. In psoriasis, it actually can have some function there, in theory at least. So what do we do with this information? I think one of the things that we don't quite understand, our approach to all these cytokines tends to be rather limited to what we know about and the milieu it is. What we don't have sensitivity always is in different tissues. These cytokines actually can have very differing or even opposite roles. So that's part of like our science, I think, is somewhat like we have hammers and we need fine instruments to really delve into some of the more complicated cytokines that we have. So that's how I think about IL-17, kind of the more mysterious one that has more features and functions. But because of that, you might not want to mess with it too much either. So that leads us to IL-17F. So IL-17F and A share some overlapping biology in terms of psoriasis. They are the most homologous two members of this family. So they share about 55% similarity between IL-17A and F. So they're the most similar members of this family. And they have pretty much overlapping features. Now, one of the reasons that IL-17A was first targeted and that there has been, I think, more recent understanding and attention to IL-17F is because initially it was thought that IL-17A was the more potent inducer of inflammation, right? These were, again, with those early preclinical studies. But there's a couple of things that kind of rise to the top when you think about how to put this in perspective. When you look at the levels in tissue of IL-17A and F, you actually have much higher levels of IL-17F. So that somewhat makes up for the relative lack of potency, if you will. But again, in the right milieu and combined with TNF-alpha, such as in the joints and in the synovium, IL-17F really seems to have a much larger role in inflammation in certain areas. So that's why we're thinking about the joint disease, about the synovial fluid. That's where IL-17F, I think, really has its increased potential in terms of as a therapeutic target. When you think about how to think about IL-17A and F in the combination, these actually function as either homodimers or heterodimers, so it can be IL-17A and A and F, or F and F. And depending on which one of these, they actually have different inhibitory potencies, relatively speaking, but they all kind of coexist together. So when you think about the protein expression elevated in patients with psoriasis, this is what I was talking about earlier, where you see IL-17A is elevated in lesional skin, right? And it's certainly, P is less than 0.05, so it's statistically significant. But when you think about IL-17F, you can see right here, much higher levels, so much higher expression of IL-17F in lesional psoriasis skin. That really makes it a much more abundant cytokine in these tissues than IL-17A. So that's where some of the thought behind targeting it comes from. When you think about IL-17F, also very much significantly elevated in hidradenitis suppurativa. And we're actually just at the tip of the iceberg here because we see it also in inflammatory bowel disease and as well looking at atopic dermatitis. So I'm going to pause a second because I think there are some other nuances between IL-17A and F that are really important to think about. One of those is looking at inappropriate bone growth. So one of the things that we see actually in psoriatic arthritis is you get these like kind of bone spurs, right? These bony overgrowths where you're not supposed to. And it seems that IL-17F works synergistically with IL-17A such that both of these together really promote that kind of inappropriate bony overgrowth. And the other really important thing that I think we should think about is in the gut. So we know that IL-17A and F are both overexpressed in the gut. That's some of the reasoning behind originally thinking about targeting IL-17A in terms of treating inflammatory bowel disease. Of course, we know that that seems to be a double-edged sword, and we've since understood that a little better. One of the things that IL-17A does is that it modulates the expression of occludin, such that when you block IL-17A, it actually makes the gut more permeable to microbes and actually can paradoxically increase gut inflammation. It seems that IL-17F really has the opposite feature in inflammatory bowel disease, where when you block IL-17F by itself in multiple animal models, you actually will improve colitis in an animal model. So that's an important distinction. And they actually did some studies with blockade of IL-17A, IL-17F. They showed both ways IL-17A is deleterious. IL-17F blockade can be protective. But when you block both, it seems like the protective effects of IL-17F outweigh the deleterious effects of IL-17A. And again, this is preclinical models and animal models of inflammatory bowel disease, but really interesting things to think about, some of those nuances between these different cytokines as part of the same family. So I think we should cover this one, our current understanding of the key cytokines. So this kind of brings it all home when we're thinking about the IL-17 pathway. So we have that activated dendritic cell, we have the IL-23, the Th17 cell pathway, and increased expression of IL-17A and F. And then we have, you see here, that kind of feedback loop with IL-17C down at the bottom, and then we have the involvement of chemokines and immune-like cells that just serve to perpetuate that inflammation. So just in summary, plaque psoriasis is the most common form of psoriasis, but we know that there are systemic manifestations. Psoriatic arthritis is important to keep in mind for our patients because it's a progressive, destructive joint disease. And IL-17A and F have emerged really as the key drivers of inflammation in psoriasis. There's some other members of the family that are kind of interesting, but they're a little further behind. And perhaps the benefit, the relative benefit of targeting them, one really wonders if it makes a lot of sense. With the precise functions of some of these members are still unknown, I think we're off to a great start, and our understanding of psoriasis has really improved a lot, and we're looking forward to it getting even better. So thank you for your attention, and if anybody has any questions, glad to take them.